very different for Boston Medical Center, which is not different from most organizations. In the past, we always begged, borrowed, and stole from our clinicians to accomplish any goals in all of our projects. And that was always a challenge. You know, we'd get their time, and sometimes they'd be available, and sometimes they weren't, or they'd be gung-ho at the beginning, but as their chief and chairs were telling them they've got to do more, their availability waned. This time we bought the clinicians' time, and that's a big difference. We've got a lot of clinicians on our project, and we're paying for their time. We bought their time, and the expectation set forth by our Chief Medical Information Officer, who's leading them, is that they will supply their time. And so I don't get any problems anymore. Not only are they excited to be part of the project, they bought into it, they're part of that team. And then we are identifying partnerships. So I've spoken with many of you, and I've spoken with many people in this area. And what we're trying to do is have strategic partnerships of how we can help Boston Medical Center. I said we have a lean budget, and that's not a lie. It is not cheap comparatively, since it is an Epic implementation. But we don't have a budget like others where we will have a significant amount of consultants for the life of the project. So instead we're staffing to demand at different phases. So that was something that we're doing differently than maybe other organizations who have a little bit more of a leniency to bring on consultants throughout the project. We're bringing them on for different phases as needed. So we'll be working to do so, and we're identifying it based on the project plan that I'll talk about in a minute. We set a project governance. We paired up our clinicians with our analysts. At the bottom level of the project governance is what we're considering work streams. And we set the work streams, again, I talked about providing more opportunities. So our team leads are actually running those work streams. They're our project managers running those, and they're paired up with clinical leads, and they're partnering together with their analysts and additional clinicians that those clinical leads have brought in. And they're running those work streams. They're empowered to make those decisions. They are running, but also have support. And so that support comes on the way up in terms of Epic leadership. So we now have a regular leadership group that meets every 2 weeks with VPs, and every week with a core group of us to stay in touch. I'll talk about the way we stay connected with communication in a bit. But this group really helps set the framework. We make a lot of decisions, and we push back a lot to make decisions at the work stream levels. We want the clinicians and the staff together making those decisions and funneling those up. And then finally we have a steering committee, and we had to have support from that group. So we pushed that off initially. We went back and we set up that steering committee. We brought on clinical leads that would help us chair this initiative. So we have VPs, strategic VPs as part of this, as well as strategic chairs and chiefs from surgery and medicine that will help us get through this implementation. They understand the goals, they understand the need for the scope, they understand that we are going to have to say no to some of them, and some of what they want will not get accomplished. And so it was important to get them bought in from the beginning, so that when we go back and tell them no, or we tell them yes, but this has to wait, or you have to do it differently, or you have to change your workflow, they're bought into it. And we've already utilized them several times, and it's been successful. So the timeline. This group got started running, and we worked with Epic, and they made this nice pretty slide that talks about their phases and the timeline set forth, and it looks so accomplishable, and everyone says your timeline is aggressive but accomplishable. I heard that phrase many times. As we got into it and we started building up the project plan, we brought on a project administrator to help, and have a fantastic project manager. And as we started doing this, we built out our Gantt chart, and we look at, there is no buffer, there is no room for error, and there is no time in between anything. So when we look at this, pretty slide, realistic slide. We have no room for error. And so my CIO talks about the perfect storm. He talks about ICD-10, meaningful use. He talks about the waves. He's a sword fisherman. He knows that everything's coming at the same time, and there is no room for error. So when we look at this and we get into it, it's got to be tight. It's got to be well disciplined. It's got to be well organized. And so that's what we spend a lot of time in the early stages doing. Really organizing ourselves, establishing the plan, and identifying how we're going to do this project. As you can see, the timelines overlap each other, and so there's a lot of coordination that needs to happen. So, again, I go back to the beginning. We have to do it differently. So a few of us sat down and we wrote something that we consider our guiding principles. And this has set the framework and the foundation for which we are running this project. We highlight these at the beginning of all of our clinical sessions. We highlight these as the different phases move on, and we remind ourselves that this is what we need to do it differently and to be successful. So, first and foremost, we acknowledge we purchased the first class EHR. We did not buy the cheap one. We did not buy the one that other academic facilities are not implementing. And we bought one that comes with what they consider a model system, or now they've changed the term to a foundation. And we acknowledge that many other academics are no different than us, and that we should be doing similar to them. And if we're going to meet this timeline, although our clinicians always think we're unique and always want to customize to make something unique to their departments, we need to follow that framework. So we start with, first and foremost, we're going to implement their model system. We know that their area, their model system in the specialty areas is a little weak, and that is where we're focusing, and actually that's why, one of the reasons that our timeline got extended on the ambulatory side. In addition, we continue to remind everyone that we're meeting and rushing against the timeline for regulatory compliance. And ICD-10 and meaningful use are not movable dates, although we hear in the industry that there's talk of moving them. We have to go blind to those and go forth as if they're not moving. Meaningful use in particular carries significant financial risks, not the opportunity costs of money we would get, but more so the financial costs of those penalties would be a lot more significant to us, especially on the hospital side, where we're already going to have recouped the majority of the money. And the opportunity to us is very small, but the penalty is quite large. In addition, we made this a clinician-led initiative. I've said that over and over again, and we really feel it. Led by our Chief Medical Information Officer, we have a Chief Nursing Information Officer. My co-sponsors are our Chief Quality Officer and Chief Technology Officer, and our Chief Nursing Officer are the co-sponsors of the initiative. The clinicians are empowered to make decisions, and I talked about the work stream levels. They're on there. They understand they should be making those decisions. In the past, everyone wanted to make a decision and then bring it to someone else to actually make the decision for them. We had to do it differently. We were never going to accomplish this goal in the time frame we had if people were afraid to make a decision, put their necks out there, and sign to the line that this is what we want and this is the workflow we're going to establish. The old ways had to go. People making decisions now, and it's working. And I think the clinicians enjoy the fact that they're empowered. They're hearing from their chiefs and chairs that it's okay to make those decisions, and that we have a clear escalation path if they truly can't come to a consensus. We had to challenge the current thinking and eliminate the status quo. We have always morphed our systems to meet our kludgy workflows, and that had to stop. And so right from the beginning, our Chief Nursing Officer, I heard her say it many times to her staff, it did not have to come from IT, because no clinician likes to hear from IT that you do something poorly or that you should change your workflow to meet an IT system. It had to come from the clinicians. And so she was very loud and vocal about saying, challenge what we're doing today, question why we're doing it. It probably made sense at the time because of the situation we had. Why do we do it any different from other academics? And can we use the model system to introduce new workflows? So there's several examples already where we are changing our current environment. And wherever possible, we're changing it ahead of EPIC to mitigate our risk at the time of go live. And then finally, go live is just the beginning. For years, we've been telling people, we can't do everything, we'll put you in the queue, we'll get to you next. People don't know where their requests are. We have acknowledged that we can't do everything with the initial go live. And so one of the key things we're also doing is prioritizing that effort, identifying what is post-live optimization efforts, and then we will have a clinician group that will then prioritize those, will publicize those, and make them available for the clinicians so they understand where the different efforts are and where they sit in those, in the work queue, so to speak. Most clinicians are happy once they know where they stand and that something is not just sitting in a black hole in IT. They understand that. And so, surprisingly, I've been extremely surprised at the amount of support for this. Of people pushing for things and saying, well, we can do that post-live. The more we push back, they acknowledge the fact that it would be fantastic. We are keeping, part of our scope documentation is identifying those post-live optimization efforts. And we have a point in the project plan that we highlight to them that shows at what point in the project we will go back with the clinicals, the clinical leads to actually prioritize that effort. Organization is critical, and so that's where I harp on the fact that I have a fantastic project administrator and an excellent project manager to keep us running. So my team is responsible for feeding information up on the right-hand side. Left-hand side? It's on the right down here. My work streams feed up on a weekly basis project status reports. They have to provide status updates regularly. We have regular checking calls from them. Every single day it's organized in a pattern. The day of the week, the information that has to flow to different groups. We start on Tuesday, Wednesday, and Thursday. Information goes to different groups. We're well organized to the point that now we've even changed the workstream meetings all have to happen at the beginning of the week, so the information flows throughout the week, so that we're not always trying to go back and forth based on people's questions and the information that has to go. Well organized effort. We keep a status that we highlight. We send this on a weekly basis to the to the leadership team, and on a bi-weekly basis, I think, to the steering committee. So they are apprised of the project. And now EPIC has implemented their monthly status report that goes up to our CEO and our steering committee that will keep them apprised from an EPIC standpoint of the project. Well organized, well communicated project, critical to the success. And then what I will say about that project plan and that effort, the one thing that doesn't encompass is the fact that Boston Medical Center can't stop what we're doing today. As much as we're pushing back about slowing down, it doesn't seem to slow down for my team who's supporting the legacy group. So I still oversee the legacy systems. That really hasn't slowed down. And as much as we push back about that, we're getting to a point that it's coming to a hard stop, and we've been pretty clear about that, and we're getting support from our VPs, but that hasn't stopped. And so to this point, we also have to look at what is still required. And it's not just the small things, but it is the ICD-10s, remediation plans, it is meaningful use, it is our project management office and the initiatives of the organization that tie into the strategic plan. So we've tapped into the interdependencies that we have in the organization. Not that we're running them, not that we're getting consumed by them, but that we're tapped into them so we understand the implications on our project. We understand if there's delays elsewhere, how that impacts our timeline. The remediations for ICD-10 in particular, upgrading all of those systems as we get into our testing phases, how that's going to impact our EPIC project, and quite frankly, how we set the stage and how my project leadership team has set the stage for that team to have to complete by certain dates and times in order to not throw off our project. And so that's how we've dealt with the interdependencies there. So EPIC has a good install process. So if you're going down the EPIC road, one of the things they do is they incentivize you for doing it their way. They tell you that they have a tried and true method, that you will be successful if you follow their methodology, and because of that, they'll give you incentives. So one of their primary incentives is that we all have to be good to each other and share well. So I will leave you to stay away from my staff. So with that, are there any questions? Yes?
I'm curious about your project management. Are you following the methodology you already had in place, or are you following the methodology that EPIC has recommended?
We are not following the methodology that we had in place. Boston Medical Center has a newly formed PMO. So our project manager was part of that PMO, so to that extent, but in terms of the methodologies and the documentation structure, all that was brought on. And quite frankly, our project administrator, who we brought on, Jeff Rockowitz and Associates, had a lot of that with him. And he had implemented many systems in the past, and so we're really relying on his methodologies as BMC is becoming more mature with our project management office.
Regarding communication, can you describe on your team who's responsible, how frequent, and what method?
Good question. So my main point on my team is Tom Bago, smiling back there. He's our project manager. He is the point, but we actually brought on a communications lead as a private consulting group, Ball Consulting. We brought him on to help us with communications. We helped to set the communication plan. In terms of frequency, I'd say communication is one area that we know today. We've done a great job within the project. We have done a lot within leadership. Today, one of our focus, we just talked about this week, is that it's time we need to get out to our end users who are not part of this project. And so I'd say the frequency there is not enough yet, but now that we are 12 months away from go live, we're going to start the process and start getting regular words out. But we do things in terms of a manager's newsletter that we contribute to monthly, so we get out to leadership that way. We've done a kickoff session in terms of our CEO's open forum session. We did one there. We had an open presentation where we did a communication talked about the scope, and then we had Epic do a demonstration as an open session to the entire organization. That was highly successful. We had standing room only for that session. In addition, internal to the project, I talked about the different ways we communicate through those levels and the chairs, and then they're disseminating. And then we have gone to med-exec steering several times as well, and we will continue to throughout the project. I'm sorry, the other thing we're doing is developing web content today, and we're looking at other modalities for communication. And we started off with the premise that this was really going to be internal communication. We talked about will this be an external communication, and we decided it would be mostly internal until the go-live process, and then it would be important to make sure the organization highlighted what we were doing so that our patient understood what we were going through. Epic is a large implementation, and so they would understand, Epic has warned you about delays that go live, especially in the ambulatory environment, which we're trying to mitigate. But in addition, just to understand the effort that Boston Medical Center is putting into this project to make sure we publicize that. So at go live, we will publicize that to the patients as well.
I've got a question for that. So my question is about mastering and the approach for what I'm going through many systems, which you have right now today, so what is your approach for making sure that you're getting accurate communication information from all the existing source systems into that?
In terms of the content that we're developing, or in terms of the data that we're converting?
In terms of the data that you're converting.
Data conversion is a hot topic with our clinicians right now. Our approach to conversion has been trying to stay consistent with what other organizations have done. And that has been a limited time frame engagement in terms of how much data we're back converting. We are also going to leave our legacy systems available to our clinicians for a period of time. In terms of I think your question was more about how to ensure the accuracy, so our approach to that will be, first and foremost, to establish how much data we're going to convert. So our scope today calls for several years worth, and we're going to employ clinicians to help us with that process. So we've got part of the project plan is to bring on a group of clinicians to go through a QC checkpoint on that data. We do know of other organizations that have done this, and they're close to go live. If it's not accurate, it's not worth it. So our process has been, if we can't make it 100% accurate, we're not going to convert it at all. And so we've set the stage with the clinicians and our steering committee that we are going to put forth the best effort possible to convert as much data as possible. We've set the framework of how much time we're targeting. They like or don't like that. But in addition, we've also been very clear that if we can't do this, we will not throw off our timeline because of the conversion of data. That has been a challenge for us in the past with other large projects, and we will not throw off our timeline because of it. So we will do it different ways, whether we can present our legacy systems through Epic, whether we can keep them available to them for an unlimited period of time. The pain point is they have to go into multiple systems. We are also acknowledging that the amount of discrete data that we will convert is going to be limited because of the risk there that you referred to. And they're more likely to get readable view data that for the discrete aspects of med problems and allergies, they'll have to re-enter into the system. So we'll have a strategy, whether we're able to pre-enter some of that for patients that are coming in the near future. We don't have that clearly defined today, but we have a work stream actually set up that is defining that as we speak.
Oh. Yes, hi. I noticed on your aggressive project timeline, you had a key item on there about workflow analysis, workflow development. I'm wondering if you could describe your approach to using process management to help manage all the changes that would be involved in this.
Yeah. So today we're in what Epic calls the validation stage. That's the name of their phase. That's really establishing the workflows. So that's one area. When you asked me before about methodology, I guess it's a hybrid. I guess I didn't answer that correctly. So we certainly have to follow we are following the good install. And so part of that is following their methodology. So their workflows, they come on site. If you haven't worked with them, they come on site. They send this big horde of staff that will come on and go through their workflows. And they show them to clinicians, and then we say stoplight evaluations and red light, green light, and have the clinicians identify, does this work for us? could this work for us, even if it's not today's workflow? So that's how we've done that. In terms of a change management, we're setting up a change management process more towards the build, I would say, in terms of as we're developing Epic, how we will have project management methodologies in place to ensure that we are not stepping on each other's toes as we develop the system. But in terms of the workflow, it's really using Epic's methodology for establishing those workflows.
Yes, hi. I was wondering, I was curious, what version of the Epic product is EMC planning to go live with?
Yeah.
And if there was any type of decision point assessment that you had to do to come to that conclusion?
There was, and we're going live with 2012. Epic is coming out with 2014 at the end of the calendar year, I believe, generally available. I was an advocate for not doing that because of the timeline constraints. Our testing begins in November, around the time that they would be introducing their new product. So because 2012 is going to be meaningfully Stage 2 certified, and because they are already ICD-10 compliant in that environment, to us it was not worth the risk of introducing an upgrade in the middle of the testing and throwing off our timeline because of it. But it was a real decision point because we also had to recognize that because of ICD-10 and then the timeline for our ambulatory environment, we're not going to upgrade to 2014 until after the ambulatory go live. So we'll be in 2015 midway before we do that upgrade. That was a big decision point. I know that was a fight between IT, some of my technology counterparts who wanted the best and the newest and the greatest. But in the end, the risk of the project and the timeline was too great to introduce a risk like an upgrade. Epic, you hear, does a much better job of QCing. My experience with our existing systems is not so, and I wasn't going to allow that risk. The problems that I've experienced with upgrades would be too great to do that a couple months before go live. And then the training aspect. So we're going to start training right after the new year, and we're going to train them on an environment so it doesn't give any time for the new workflows and the new training environments to be set up, as well as any content changes that would need to be made. So it really wasn't a decision, a hard decision. It was more the acknowledgement that we were not going to upgrade for an entire year after.
So what were your lessons learned at this point? I know that you'll have more in 6 months, but you had to look back and say, oh my God, we really should have thought about this beforehand. What can you share with us?
Real estate was a huge issue. We had to hire a lot of staff, and our IT was already busting at the seams, so we needed to find space fast, and that became a challenge. And it became an internal challenge because of the location of the building and the framework of how we were going to include the clinicians in the project, and whether we were on campus or not. We started going down the road of not being on campus, and we wound up on the road of just being down the street. That was something. Looking at the go live strategy, we initially showed our timeline. We initially were doing a split go live, but it was only 2 months apart. We were originally doing ambulatory first in April of 2014, and then June of 2014 was the inpatient. And when we got into it, we relied on the pretty slides of Epic. And when we got into the project plan, we had the panic attacks of accomplishable, but aggressive is an understatement. It was going to be a challenge. And then more we got into it with the amount of clinicians we have, and I know there's a lot of academics here and other places implementing Epic. The amount of clinicians that we have and the amount of specialties we have, when we got into it with Epic, they agreed that that really wasn't a realistic goal. So.
And why don't we just do 2 more questions?
Can you talk a little bit about the infrastructure changes or upgrades that were required for this?
We have a complete infrastructure change. So because we're best of breed, we've struggled for years on areas like citrus. We run 4 different citrus farms today, and none of them are the latest because our systems are outdated, because we constantly wish to do projects and we don't have time to do the upgrades. Our systems are constantly outdated. That's a major area. We've also are changing our strategy around devices. So in the past, we've done a lot of, everyone hates the term cows, wows, whatever you want to call them. We're actually moving to a strategy of putting PCs at the bedside. In the past, we had done assessments with our clinicians, and they didn't want it. They wanted the nurses in particular wanted the mobility of going around. Driven from senior leadership, we looked at the cost and we looked at strategic direction of how the chief nursing officer wanted her nurses to interact with patients, and she wanted them at bedside, and she wanted to ensure that. And so we're going through and we're adding devices at bedside. So that's a big, it's a significant change for us as well. But otherwise, it's almost a new environment. We had upgraded our wireless, which was a major concern a few years ago, caused us many issues. That's pretty rock solid today, and setting a good foundation for that. In addition, we don't have a large mobile device strategy. And so with Epic, that's one of the toys that they'll throw at the clinicians. And you don't throw in a system like this and not introduce some perks. So that is one of the changes from the like for like. So we're going to have some mobile device solutions. So we're getting geared up for that.
Did your ACO plans or commitments impact the decisions you made?
I don't know if it impacted our decision, but it impacted our contracting with Epic, in that we made sure that we set ourselves up through contractual obligations with Epic to set the framework of expanding to our and growing our relationship with our health centers. We talk about the continuum of care with our clinicians. The majority of our referrals are all from those 15 community health centers. And the ability, and most of our clinicians actually work in both environments. So today, on top of logging into all these systems at BMC, they also log into the health centers, and they, at the health centers, log into our BMC environments. So the ability of having one integrated care record with the health centers is a goal and a very real improvement from our current state. So I would say from that aspect, yes. And we certainly have other clinical groups that we work with, and we've identified how we can integrate them with Epic and how we can use their Connect program to do so. But it was really about the health centers in terms of that strategic piece.
Great. Thanks a lot, Eric.
Thank you.
Just like that, we have another table on the back. So thanks everyone for kind of squeezing around the tables. There are enough chairs, but I think it's probably a good opportunity anyways. If there's more questions, by the way, for Eric or Lisa or anyone, come up to me and let me know because they'll be here too. But we can certainly tweak. If we do have 5 minutes or 10 minutes, depending on how the flow goes today. Would definitely like to take the opportunity if they're around and have them come up and answer a few more questions because you can definitely tell from the vibe in the room that people are interested in this topic and it's impacting you. But with that said, we will continue with the flow of the day. I'm going to switch it over to Kevin from Beacon Partners, and we'll do introductions and move on. Thanks, Peter.
Hi, my name is Kevin McKittrick from Beacon Partners. It's my great privilege to introduce our next guest, Lisa Stump, Vice President from the Only Haven Health System. Lisa is responsible for the implementation of Epic EMR and revenue cycle applications of the Only Haven Health System, the hospitals, Northeast Medical Group practices, Yale University faculty practices, and health plan, and affiliated community practices. Lisa is a licensed pharmacist, and before becoming a leader in healthcare information technology, held a series of management and leadership positions in hospital